Hi everyone, thanks so much for joining us for today's Emmy webinar. Today we're going to focus on Medicaid linkages, how we can connect Medicaid enrollees to other key supports. So we are going to start with a summary of different cross-enrollment opportunities, the policies at the federal and state levels, and some of the practices that can connect Medicaid enrollees to other programs that can support their health and well-being. We're going to take a deep dive then into a couple of these areas. The first one will be a focus on WIC, a really key program to support people's nutritional health. That is a great opportunity for Medicaid enrollees. Next, we'll look at how we can use SNAP data for Medicaid enrollment and renewal. And finally, we'll look into the expanded child tax credit and what the opportunities there are to connect Medicaid enrollees to this quite substantial and newer benefit that is going to be really helpful for families. And of course, at the end, we'll have some time for questions. Should have said this at the beginning, but I'm Jen Wagner with the Center on Budget and Policy Priorities, and we're excited to have you here. So let's talk a little bit about linkages. What do we mean when we say linkage? We define linkage as a federal eligibility rule that permits or requires one program to adopt in whole or in part another program's eligibility findings. Typically kind of wonky discussion, but the way I simplify it is because you are approved for X, you can also get Y without going through the full process. X being one program or benefit and Y being the other. Now, these connections could be automatic. It could be because you got one, a second comes with it automatically. Or it could be streamlined because you are approved for one process, you're also income eligible or otherwise eligible for a program, but you still have to select a plan or do something else to actually achieve that benefit. These linkages also could be mandatory. All states are required to do it. It could be a state option where the state gets to elect to do it or not. Or it could be a little more of an innovative practice, a pilot or a waiver that is being tested out in some states. At the bottom of this slide, I've got a link to a paper on linkages that's from a few years ago, but my colleagues at the center did really going through a number of programs and outlining the different connections between all of them and where there's a mandatory connection, where it's a streamlined enrollment, where there are waivers, all of those things. So a really useful paper to look at both Medicaid and some other critical safety net programs and how they're interconnected. So from that paper, let's take a look at the Medicaid chart. A little bit intimidating at first, but don't worry, it actually says a whole lot of information on this single page. So this is a chart focused on Medicaid. And you'll see on the left side, programs that kind of feed into Medicaid. If you're eligible for the program on the left, you may be automatically or have a streamlined path towards Medicaid enrollment. For most states, the obvious one is SSI. In many states, just being on SSI, being approved for SSI, means that you automatically get Medicaid along with it. In other states, it's more of a streamlined path, but it's a similar idea for TANF in many states, and there are connections with SNAP, which we'll talk about later on. Then on the right side of the chart, you see the things that kind of come out of Medicaid. If you've been approved for Medicaid, you have an expedited pathway into these other programs. For example, Medicare Savings Program. If you're a low-income senior approved for the right category of Medicaid, the state will automatically pay your Medicare premiums and supplement it. Low income subsidy doesn't always get operationalized as it should, but there should be a connection there. Similarly, there's a streamlined connection to other programs like WIC, which again we'll dive into more shortly, as well as things like Lifeline. And that really kind of exhibits the idea of a streamlined, not automatic enrollment. If you think of Lifeline, which are the subsidized cell phones, you don't automatically get a cell phone when you get your Medicaid card. But because you have Medicaid, you're eligible for Lifeline. So you still have to seek out a service provider. You still may have to select a plan, get a phone that's eligible and all of those things. But the income eligibility part is taken care of because you're on Medicaid. You don't have to provide pay stubs or anything else like that. So I encourage you to take a look at this paper. It's got a number of very useful charts. Again, covers different programs. SNAP is kind of considered the gold standard in this world because it is so thoroughly verified. It is used for many, many other programs. Medicaid's kind of in between. Some feed into it, some feed out of it. Others are actually isolated from other programs. So it's an interesting discussion to understand what the federal policy landscape is around these different programs and where some opportunities may be in your state. So when we talk about linkages, why does this matter? Why is this worthy of a webinar and worthy of your attention? Well, there are a lot of advantages to using these linkages to the maximum extent possible. Fundamentally, it can connect individuals to additional benefits. We know that when low-income families seek Medicaid, they often don't just need help with health insurance. They need help with feeding their children. They need help with childcare and other services. And this can kind of help give them a foot in the door and ease the pathway into these other programs. If they have to go to each individual program and do the same application process and do a full verification of eligibility for each one, that's overwhelming. We know being poor is already essentially a full-time job. So how can we kind of simplify things? Which goes to the second point of minimizing paperwork burdens. If one program accepts the finding from another, then oftentimes you don't have to submit all the same information again, gather the pay stubs and other proof of eligibility. There are also a lot of advantages for a state or local agency here. Their process is simplified. They can just see that you're enrolled in that other program, take that eligibility finding, and then focus in on their nutrition counseling, on providing their cell phones or whatever their program might be. And finally, these linkages can be taken advantage of both at an application as well as at a renewal. So when a program is looking to see if somebody continues to be eligible, they can leverage enrollment in another program in order to renew. And this is another huge simplification for both the client and the agency. And it can really minimize churn by keeping individuals enrolled. But like anything, it's complicated. So there are some other considerations when you look at how your state is implementing some of these linkages. First, has the agency adopted the option or waiver? Like we mentioned, some of these are kind of mandatory and states have to do it, but some are state choices. And have they really capitalized on the different opportunities to maximize across enrollment opportunities for their residents? Another consideration is the referral process, the other benefit. How does somebody know that they're eligible for another benefit or that there's a streamlined enrollment pathway? Are they told about it? Is there some sort of a warm handoff? Is there a co-location or something to make sure that they actually take that step to connect to the other benefit? Next is their data sharing. So if you look at the second benefit that they're eligible for because of the enrollment in the first benefit, how does the entity know? Can they do a data lookup and see, oh, I see you're enrolled in SNAP, therefore you're eligible for school lunch or whatever it might be? Or does it require the individual to somehow go get proof that they're enrolled in Medicaid and show it to the other agency? Where are opportunities to really kind of maximize that simplification? And finally, these linkages provide some great opportunities for active outreach, or some people would say in-reach. So if we know that everyone enrolled in program X is also eligible for program Y, but many of them aren't enrolled, how can we utilize the fact that we have their names, we have their phone numbers, we have their information, and reach out to them and say, hey, did you know that there's this benefit that you can connect to? Let us help you. It's a streamlined process, and do some of those connections on behalf of somebody, and really help them get connected to the full package of benefits for which they're eligible. So that's a brief summary of the linkages and why they're important. I'm now going to hand it over to my colleagues Zoe and Lauren to talk specifically about WIC and how this can be capitalized. Zoe?
Thank you so much. So we're going to spend about 20 minutes on WIC, and we'll cover 4 main areas. I'll go through some of the basics of how the program works for those who aren't familiar. We'll talk about participation trends, and then I'll describe a promising approach to enrolling more Medicaid participants in WIC. And finally, I'll conclude with suggestions for how each of you could help strengthen ties between Medicaid or the broader healthcare system and WIC. So WIC is an extraordinarily effective program. You can, in the next slide, you'll see some examples of that. And it has a very strong body of research demonstrating that. So WIC is associated with healthier births, better diets, stronger connections to preventive health care, improved cognitive development. We have lots of materials synthesizing the research here available for you. Who is eligible for WIC? In the next slide, you can see that it's pretty straightforward. For pregnant individuals are eligible, children up until their 5th birthday. And then postpartum individuals for 6 months, whether or not you're breastfeeding, and up to 12 months if you are breastfeeding. The income criteria are that your income has to be under 185% of the federal poverty line, or you have to be receiving Medicaid, SNAP, or TANF cash assistance. And The policy that allows automatic income eligible for those recipients is referred to as adjunctive eligibility. For Medicaid, it does not matter what the state Medicaid's limit is and how it relates to that 185 that's used in WIC. If you're getting Medicaid, you are automatically income eligible for WIC. And that applies also to people who are in a CHIP-funded Medicaid expansion. It does not apply to separate CHIP programs. And then the last criteria is that you must be at nutritional risk, but basically the categories are broad enough that everybody who's at these income levels is determined to be at nutritional risk. That nutrition risk assessment is really used more for targeting counseling and tailoring food packages. As part of the enrollment process, WIC requires documentation of three things: identity, residence, and income or adjunctive income eligibility. WIC also collects heights, weights, and blood work at the initial certification and then usually another time during the year. So what are the benefits that WIC provides? WIC is a food assistance program, and it does provide a science-based food package. It also provides nutrition education, breastfeeding support, and referrals to health and social services. So to give you a little bit more of a sense of the food package that WIC provides, the average value of that across all participants is about $61 a month, but there's wide variation. WIC provides infant formula, which is the most expensive item in the package. And so the value of the package for an infant is almost $150 a month, whereas it's much lower for pregnant and postpartum individuals and for children. For children, it's only about $34 a month. It's important to point out that WIC is able to purchase infant formula at tremendous discounts. So the figures that I'm showing you here are the value to participants. They are not the cost to the federal government. So that's it on the basics. I'm going to turn now to talking a little bit about participation. So USDA every year analyzes the measure of the share of eligible individuals who participate in WIC. And in WIC, that is referred to as the coverage rate. USDA has been doing this annually since 2005, and what you're seeing here is from their latest report, which was just released about a month ago. You can see that for a few years, WIC was reaching more eligible individuals than less. There's a break in the data between 2015 and 16 because of the change in the underlying census data that's used. But I think the key takeaway here is that for the last 3 years for which we have data, more than 40% of eligible individuals are not enrolled in WIC. That's where we have a lot of work to do. USDA analyzes the data in lots of different ways. There's a lot of state-specific data, so you can look for that. The next slide shows you a breakdown by category. So you can see the tall columns are for postpartum individuals and infants who are enrolling at very, very high rates. So that's not really where the concern is. The issue is reaching more pregnant individuals and retaining more children past infancy. You can see there's a really steep drop off to either keeping children on or for those who have left, getting them back on. And another way that USDA analyzes the data is by race. So this chart shows racial breakdowns by type of participant, and just a few takeaways here. WIC reaches a greater share of eligible Black and Latino children than white, which is a good starting point for reducing racial disparities in child health outcomes. But that is not true for pregnant individuals. WIC is missing a greater share of Black and Latino individuals. So it's important to explore and address that. And then stepping back from the comparisons, this just tells us again that more than 40% of eligible Black and Latino children and 40% of Black and Latino pregnant individuals are missing out on WIC, which in my view is far too many. So my colleague Lauren has been doing some analysis of WIC participation over the last year or so during the course of the pandemic. So I'm going to turn it over to her to share some of her terrific work there.
Great, thanks, Zoe. So in light of these trends over the past few years where we've seen the WIC coverage rate going down, we have been monitoring WIC participation very closely during the pandemic. Initially, we would have expected to see very substantial growth because of the spike in food hardship and job losses. But in actuality, nationwide participation has increased by only 2.5%. Growth has been higher for infants and children at about 5%, And among children ages 1 to 4, it's nearly 10%. So this is all good news. But what these figures don't reflect is that there's actually very wide variation among states in terms of their change in participation. So if we could actually go back to the previous slide, the chart shows that the change in participation by infants and children for each state between February 2020 and February 2021. The dark blue line towards the center is the nationwide figure, which is about 5% growth in the past year. And each of these other lines here represents a state. So there are some states with larger increases up to 25%, which are in light blue, while there are other states that have lower increases or declines, which are shown there in yellow. And so you might be curious about where your state falls in this mix because it's a pretty wide spread. So if we turn to the next slide, this is showing the exact same information, but this time it's in the form of a map. And so the states here are color-coded according to their participation change. The states that are in dark blue had higher increases, while states that are gray or light blue have lower increases or declines. And so we're concerned about those states that have lower increases or declines because it means that WIC benefits haven't been getting out to people during a time of really high need. And so now I'm going to turn it back to Zoe, who's going to compare WIC participation to Medicaid during the pandemic and talk about next steps.
Thanks so much, Lauren. So this next chart shows you WIC growth in yellow, Medicaid growth in blue over the period of February 2020 to January 2021. For WIC, it includes infants and children. Again, for Medicaid, it includes children of all ages. So you can see WIC participation has grown less than Medicaid, which is concerning by itself. But one important thing to keep in mind is that Medicaid serves many more children under 5. So if WIC and Medicaid added the exact same number of children, they would be added to a smaller base in WIC, and the percentage growth, which we're showing here, would be higher. Instead, we're not only not seeing that, but we're seeing that WIC was lower in terms of growth. Now, we are limited in what we can look at because we're limited to publicly available data, but you may have access to better data from your state that allows for a more precise or nuanced analysis. We'd certainly encourage you to dive into that. Now, as you're probably well aware, one reason Medicaid is growing so steadily is the continuous coverage policy. All of the children getting Medicaid are adjunctively eligible for WIC, even with that policy in place. And so the next few months, while continuous coverage remains in effect, are a really important opportunity to identify who is getting, the kids who are getting Medicaid and try to get them enrolled in WIC as well. So now shifting gears a little bit from past trends to looking ahead, we are not the only ones who are concerned about WIC not reaching enough of the eligible people. And there was actually a really important investment in the American Rescue Plan in WIC to try to address this issue. So WIC received $300 million to use over 4 years. In the context of WIC, this is a very large amount. And it is to be used for outreach, modernization, and innovation with the goal of increasing participation and redemption of benefits. The statute didn't say anything more than that. So we are waiting to hear what USDA will do with that money. I think the backdrop here is that WIC has been slower to modernize than Medicaid or SNAP, but even before the pandemic, there was a slow but steady progress. Ironically, during the pandemic, there's been a pretty dramatic leap forward. So just to give a couple of examples, pre-pandemic, it was very rare for participants to be able to submit documents electronically. Now that's available just about everywhere. Pre-pandemic, the vast majority of certification appointments were conducted in person. And to be clear, in many instances, that is a statutory requirement, but it is not always required. Under the current waivers, all states are offering telephone appointments. However, there are some pretty basic technologies that are still not in widespread use, like online applications, online appointment scheduling, or video appointments. So a key issue over the next year or so will be helping states retain the modernizations and flexibilities that they've been able to adopt, even when the waivers expire. Now, one area that's still unclear is to what extent USDA will allow telephone and video appointments once the current waivers expire. But even if they do, as a practical matter, to offer telephone and video appointments, WIC will still need to obtain heights, weights, and blood work, as I mentioned up front. And healthcare providers have a really important role in making that information available without requiring everybody to come into WIC so we can measure that. Now, one area that we are hoping USDA will devote some of this funding to is supporting enrollment of Medicaid and SNAP participants in WIC. And so I'm going to shift gears now and tell you a little bit more about our work in this space over the last few years. About 5 years ago, I set about trying to find examples of efforts that states were making to identify Medicaid and SNAP participants and enroll them in WIC. And I found much less than I expected. So we decided that we wanted to launch some pilots to explore what could work. First, we partnered with Benefits Data Trust, another nonprofit, and then together we partnered with 4 states to launch pilot programs. In each pilot, WIC entered into a data sharing agreement with the Medicaid or SNAP agency and received a list of all children under 5 participating in Medicaid or SNAP. All of those children are adjunctively income eligible for WIC. Their names were matched against WIC data to identify those who were not enrolled. And the goals were to measure the size of that eligible but not enrolled group. We don't have those measures nationally or state by state. To conduct targeted text message outreach to each of those families, and to very carefully monitor the results to see what impact that type of approach could have. So we now have results. We have identified 5 key findings, and I'll speak briefly to each of these. So the first is that data matching does effectively identify very large numbers of adjunctively eligible families who are not participating in WIC. Across the pilot states, we found that of the WIC eligible Medicaid and SNAP participants, anywhere from 44 to 63% were not enrolled in WIC. We also found that the text-based outreach approach is promising with regard to increasing their enrollment in WIC. In each state, we were able to keep a control group. So we were able to compare the group that got text to a group that didn't and look at their enrollment rates. The results were quite promising for Medicaid. So Medicaid participants were more likely to enroll if they got the text-based outreach. In Virginia, they were 5% more likely to enroll if they were just getting Medicaid, if they were getting multiple programs, because Virginia used SNAP, Medicaid, foster care, and TANF. There was a 9% increase. And in Massachusetts, they did something different. They matched just against recent Medicaid enrollees who had had less time to enroll in WIC, and they actually found a difference of 36% for the people who received text-based outreach. So a really big difference there. We did not get similar results for SNAP participants. They either were no more likely to enroll after getting tests or even less likely. And there were some anomalies, so I don't think we have conclusive information there. It's definitely worth exploring, though, why we saw such different results. We also found that texting is a practical mode of communicating with WIC eligible families. About 80% of the texts were successfully delivered. About 1 in 5 recipients engaged in one way or another because these were 2-way texts. And between 4 and 9% of recipients requested a WIC certification appointment. That's a relatively low percentage, but it's of a very large group. So it still made a noticeable difference in getting people enrolled in WIC. We also, unfortunately, though, confirmed that certain aspects of the WIC certification process seem to be posing barriers to enrollment. And this is probably not just true for these families, but families interested in WIC across the board. So what we found was that a substantial portion of those who requested appointments never actually got them scheduled, or if they got them scheduled, didn't show up. If they showed up, they got certified. So my takeaway from that is that it's really important to make the WIC enrollment process as simple as possible and to support families through it. It's not enough to just get them to ask for an appointment. We also found that these strategies of data matching and text outreach were sustainable once they were set up, and the states that we worked with really appreciated the opportunities for cross-agency collaboration on this project and even beyond. So to wrap up, I hope you're wondering, well, what can I do to get more people enrolled in WIC? And I'm going to talk about 3 groups, although there's obviously a lot of overlap. First is what Medicaid and people involved with Medicaid can do, then healthcare providers and advocates. So first up for Medicaid, unsurprisingly, given those pilots that I just talked about, is Medicaid can share data for targeted outreach. It could be using that model where there's a monthly or a quarterly sharing of information. It could be that you set up automatic data sharing so that every time an individual gets enrolled in the pregnancy category in Medicaid, that information is shared with WIC. Same could be done for infants or children. There are, obviously, we believe that the information can be shared, and there are states that are doing it. There are some states that do not believe that they're allowed to share Medicaid information. If you're in a state like that, or a state that simply hasn't set it up yet, a good fallback is to share information about WIC with WIC eligible Medicaid enrollees. So pregnant people or families with children under 5. Another thing that the Medicaid program can do, even if they can't share individual information, is share data with the state WIC program for further analysis, so they can identify where there are gaps and think about how best to fill them. And then another opportunity here is to create, if there's an online Medicaid application, to create a mechanism within that to express interest in WIC and to have information shared with WIC that way. Turning now to healthcare providers. As I mentioned, developing information sharing mechanisms that allow two-way communication between WIC and healthcare providers are extremely important, and will be even more important going forward to allow WIC to maintain the flexibility of telephone or video appointments. Right now, those communication mechanisms are generally pretty rudimentary. Sometimes there's an online referral form. So there's a lot of room both for technology advancement here and just establishing better communications, even if you're using telephone calls or something much more basic. I think it's important to think about what referrals look like. There's a wide range of activities that are called referrals, and it's important to go beyond just handing someone a pamphlet or a phone number. Healthcare providers could explain what the enrollment process looks like in WIC. They could schedule appointments. They could help families gather the documentation they need or complete WIC forms. And of course, Medicaid can share, healthcare providers could share information on related to eligibility and the measurement and health information that would be relevant to WIC. And then last year, I wanted to highlight the importance of integrating WIC into health services. There are lots of models for this. Some WIC programs are able to actually outstation a staff person, full or part-time, to a healthcare provider. You can co-locate services, although co-location doesn't always amount to service integration, which is the more important aspect of co-locating. So it's important to think about that. You could even allow patients to get certified for WIC during a healthcare appointment. You could have a setup where somebody gets 15 minutes during a prenatal appointment or a well child visit to sit at a computer and have a video call to get certified for WIC, and then their benefits could be issued. So last up, I want to turn to advocates, but of course, I hope that even those who are associated with Medicaid or healthcare providers would engage in advocacy in this space as well. I think the most important thing for advocates here is to help set a goal and create an expectation that all eligible low-income children under 5 will receive Medicaid, SNAP, and WIC. For us, that's a really important goal, to provide young kids who are in low-income families with the best package, the most complete package of supports that they can get, and get them off to a strong start. We have been sharing this idea with states for a few years. We haven't gotten a lot of takers, so I'm hoping there will be a bit of an echo chamber. Because once you have that goal in mind, there are lots of different avenues that you can pursue to try to get there. But you have to be thinking about it in the first place. And there's a lot of thought going into this within WIC, but I think WIC really needs support from outside of WIC, from the healthcare community and maternal and child health stakeholders to elevate this issue. Obviously, you are an audience that has a lot of experience with improving the Medicaid enrollment process, and a lot of that can transfer to WIC. Obviously, there are differences in the program, but your familiarity with Medicaid and how to make that an easier process for families and for staff can translate really well to making recommendations for WIC. It's also important to think about, particularly at the state level, diagnosing what the barriers might be. If you're in a state that has struggled with the coverage rate or has had a participation decline during the pandemic, a really important starting point might be identifying what is the holdup. In pre-pandemic surveys, there were 3 main areas that emerged. One is misunderstanding by families about eligibility. Lots of people think they are no longer eligible, for example, if they stopped getting Medicaid or went back to work, but they are eligible. There is sometimes frustration with the shopping experience for WIC foods. That's not an area that we focus on, but has a big impact on a participant's experience of the program. And then there's the clinic experience and the enrollment and recertification process, which is where we focused. And of course, once you have diagnosed barriers, it's important to start thinking about possible solutions. And we have a resource that we just posted last week that can help you with this. It's basically a toolkit on how to make the enrollment process easier for families and more efficient for staff. It's got several different topics and lots of suggestions and examples of practices that can help with that. So if you've diagnosed some barriers and you're looking for ideas to share with your state, this can be a good resource. And then our last slide, which I won't talk through, just has links to lots of the resources that I've mentioned. So there's lots more information. And of course, I'd be happy to talk more about any of this during the Q&A. So I'll turn it back to Jen. Thank you.
Thanks so much, Zoe. That's such a great summary of both the valuable WIC program as well as the complexities of linkages and how to actually take a policy and make it into reality to the benefit of low-income families. There are two questions that have come in that I want to kind of cover when we have a moment between conversations, since we've got you. The first question is, if 98% of eligible infants are enrolled, is there some procedural barrier to remaining eligible after year one that accounts for the drop-off?
Sure. So let me just say, 98% sounds a little unrealistic. There may be data issues underlying that, but the general point holds that WIC is reaching the vast majority of infants and not as kids get older. There is a recertification at 1 year, so that's a procedural potential barrier. And there is an effort in an hopefully upcoming reauthorization to extend certification of infants to 2 years to try to mitigate some of that drop off. I think the other issue is the change in the value of benefits, which I mentioned. So if you've been getting a food package worth roughly $150 and you're dropping to $30 a month, while the program basically requires the same amount of time and effort and appointments, I think that contributes as well.
Great. One more question. Can you talk more about data sharing with WIC, how that's permitted, given privacy protections and regulations and statutory restrictions on sharing Medicaid enrollees data?
So just stepping back without using a lot of jargon, the gist is that we have interpreted and states have interpreted that when people, because people are automatically income eligible for WIC once they're enrolled in Medicaid, that enrolling in Medicaid is essentially giving permission to share data with WIC for enrollment purposes. I can follow up with some resources and references in the rules that support that, but that is the basic argument that is used. And this, you know, there are several states now doing it. None of them have run into trouble or issues. I would love to see CMS clarify that, and hopefully we'll get that in the future. But that's the gist.
Great, thanks so much, and thanks so much for those questions. Please keep submitting them throughout the presentation, whether it's around WIC, something we've covered before, or something that comes up and we will be sure to cover at the end. So thank you again, Zoe and Lauren, for that information. So our second area of deep dive is we're going to talk briefly about the opportunities to use SNAP information for Medicaid application and renewal processing. As I mentioned at the beginning, SNAP is often valued in these linkages because the information is usually very current. Oftentimes there's been a review of a case within the past 6 months. It's also very accurate. SNAP requires very detailed dollar for dollar verification of income, usually with 30 days of pay stubs. And it's complete. SNAP files show what type of income it is and who is receiving the income. And that really helps to be leveraged for other programs. So this can be done at application, where you find people who are enrolled in SNAP and not Medicaid. Or in the case of Medicaid expansion, you find newly eligible individuals. So we hope to be having those conversations in the future with some of your states as you guys continue to make great efforts towards achieving expansion. When SNAP information is used at application, it does require a client to take some action to indicate that they want Medicaid. So you can't just say by the fact that you signed up for SNAP and you're eligible, here's Medicaid. But that can be really simplified. States have given people medical cards, and if they call to activate it, that counts as electing Medicaid. It could be signing a form saying I want Medicaid and not having to provide any additional information. So there are expedited pathways to make sure that people get enrolled there. SNAP is also critically important at Medicaid renewal, specifically in the ex parte or the automated process. When a state tries to do a renewal using available data sources, if the individual is also enrolled in SNAP, there are various pathways to ensure that that information is leveraged for an ex parte automated renewal, which reduces burden on the client and the agency and ensures that eligible people remain on the program. So there are three particular ways that an agency can use SNAP information for Medicaid. And I'm going to run through them briefly, but I've also got a link here to kind of a longer paper that describes a little bit of the complexities and opportunities within each one. I want to highlight that these three can be used independently or in conjunction with each other. Some have different target populations or methodologies. And it can be done whether your state has separate Medicaid and SNAP administration or whether they're integrated. There are pathways forward for everyone. So let's dive in. The first option is actually pretty straightforward. It's using SNAP income data as a data source. So when somebody's applying for benefits, for Medicaid benefits, or there's a renewal attempt, you look to data sources. The agency goes out to look at Social Security Administration, unemployment benefits, quarterly wage data, etc. Well, another data source is SNAP. And an agency can look to SNAP to see earned income from an employer, again, thoroughly and recently verified. Really valuable is self-employment income. Besides occasionally IRS data, usually there's no data source to verify self-employment income. But if the person's on SNAP as well, they recently provided that information through that pathway, and that can be leveraged for Medicaid. Similarly, there are other benefits like a pension, a private pension, that can't be verified in electronic data sources, but would have been verified recently and thoroughly for SNAP and can be used for Medicaid. And finally, there's a tricky issue at renewal, where CMS has said that if you can't do an ex parte renewal when there's no hit in the data source, even if that just means that a client has no income, as many of our clients do. But you can look to SNAP, and the fact that there's zero income on the SNAP case is actually a hit, is actually verification that the person has no income. They recently signed and submitted a form saying that they have no income, and that was verified. And so that can be leveraged for that population at renewal. An advantage of this pathway is that a SNAP case file will specify who receives the income and the type of income. People might be dissuaded because of the differences in SNAP and Medicaid household determination, as well as what is countable for income. But if the agency actually looks into the SNAP case, they can say, okay, these are the Medicaid household members that I want to verify income for, and only pull income attributed to those members. It can also say this is the countable Medicaid income and only pull that information. So it's not pulling child support or other things that are countable for one program and not the other. This is most valuable in an integrated state where some of that coding is shared. And you may find that your state is already doing this in some way, but there are opportunities to kind of capitalize on it, especially at renewal. The second pathway is the very, very catchy facilitated enrollment state plan option. This is also known as Fast Track. It's an option that came up from CMS in August of 2015. And the idea here is that you're using the SNAP gross household income to make it MAGI Medicaid determination. This pathway is only usable for non-disabled adults under 65 and children. So basically the MAGI population. And in order to use the SNAP enrollment for Medicaid, you must be certain that the individual is eligible for Medicaid. That sounds technical, but about 95% of people in this population are eligible for Medicaid. And there are just a couple of fine exclusions that a state has to implement. For example, if there's an ineligible household member in the SNAP household, that case has to be excluded because the rules are different for Medicaid. So mostly fringe things that can be programmed into an eligibility system. Some of you may remember Strategy 3 back from the ACA implementation days. And this is kind of a newer iteration of Strategy 3. It's slightly more restricted. Under Strategy 3, somebody had to be likely eligible for Medicaid. Now you have to be certainly eligible. However, Strategy 3 was limited to ACA implementation, and it could only be used once. So if you use Strategy 3 to enroll somebody, you couldn't also use it at renewal. And it's limited in CMS allowing states to do it because it is connected with ACA implementation. So again, even if there's an expansion in the future, a state could leverage Strategy 3, but it's not meant to be an ongoing tool for states. This kind of takes the place as far as more permanent option. And this counts as a full MAGI determination. So a state could use it at application and renewal, and the next renewal, and the next renewal. It can be used continuously. So it's very valuable. And this is one that might be more valuable in a state with separate SNAP and Medicaid administration, because you essentially have to check that the person's on SNAP and meets these couple of high-level requirements, and then you can leverage that for Medicaid enrollment. The third option is the one that's been around for a while, Express Lane Eligibility, or ELE. And ELE allows you to use income findings from another program, like SNAP for Medicaid. Can also be other programs that are identified as the Express Lane agency for purposes. Now, this is arguably the most kind of generous one because they really waive the different methodologies used in the different programs for household size and income. So you can kind of disregard some of those nuances and say, if they're on X program, they're eligible for Medicaid. The one thing is that it's limited to children. Except in one state with an 1115 waiver, it's limited to children. And so it's great for children. And so again, that goes to the idea of combining these in different ways that work in your state in order to cover as many people as possible. And either do that in reach to SNAP enrollees who may be eligible for Medicaid, or leverage this at renewal to expedite ex parte renewals or even the traditional renewal process and make sure that eligible people retain their benefits. Very important as we approach the end of the public health emergency and the end of the continuous coverage provision, which we expect to end around January of 2022. States are going to be having to do a lot of renewals. They should be trying to do ex parte leading up to that point, but in the course of the next year, they're going to have to do a lot. And in most cases, individuals will have been in touch with their SNAP agency before that Medicaid renewal comes due. And so there'll be current information sitting there. And it's important for a state to think about how they can leverage that to save themselves work, save the client a lot of hassle, and reduce churn by making sure that eligible people stay enrolled. So I know that was a quick summary of another example of kind of capitalizing on linkages, but we do have some material on these options and are always available for questions. So without further ado, I want to hand it over to my colleague Jenny to talk about the new child tax credit. This isn't represented exactly in a linkage. There's not that kind of automated pathway, but it's really a critical opportunity to connect low-income families to a cash benefit that is typically not available to this population. And we want to make sure that especially those who don't typically file taxes are able to access it, and Medicaid can provide a key route to that. So I'll turn it over to Jenny.
Thanks, Jen. I'm Jenny, she, her pronouns, and I work at the Center's Get It Back campaign, which is a national effort to connect folks with the tax benefits that they qualify for. Normally we focus on the EITC, but this year with the stimulus checks and the expanded Ctc, we have been very busy. And so today I will talk a little bit about the actual Ctc expansion, what that means and who qualifies. And then we'll dig a little bit into how folks can get the Ctc and ways that Medicaid agencies and folks can help. So on the next slide, you'll see there are six main changes to the Ctc, and I will just hone in on a few of them. So in the past, the Ctc was not available to the people with the lowest income. So because it was only partially refundable, it meant that people making under $2,500 did not qualify for the credit. So now the credit is fully refundable and it's much larger. It went from $2,000 to $3,000 for most children and $3,600 for kids under the age of 6. And there are no income requirements anymore. This year, they will come in advance payments. So half of the child tax credit will come in a monthly payment starting July 15th. If you go on the next slide, you'll see more details in a table in case you're curious about all of those. But yeah, just again, really want to emphasize that it is fully refundable and there's no income requirements anymore. If we could turn to the next slide. So this is a huge opportunity, as Jen said. This is a lot of cash for families who don't usually qualify. The IRS does estimate that about 88% of children who are eligible will automatically get the advance payments, which is amazing. Unfortunately, the remaining 12% of children will not get the advance payments. So automatically, at least. So for these families, it's really interesting this year because the stimulus checks from last year really brought a lot of non-filers into the tax system who wouldn't normally have filed, and that is amazing. But what that really means is that for the people who have still not yet filed, there are pretty big barriers. And so it's really important at this point to really create an all hands on deck outreach effort and to really support outreach, not just with awareness, but with support in filling out the forms that they need to get the CTC. And of course, many of these families are already enrolled in Medicaid, so this does create an opportunity for Medicaid application assisters, providers, and state and local agencies to conduct outreach to help these folks get their payments. I do also want to point out that of the hard to reach population that we're particularly concerned about, we are concerned about reaching immigrant households. So with the CTC, as with many other benefits, right, people who do not have Social Security numbers, who have ITINs, can still qualify for the CTC if their child has a valid Social Security number. So really targeting outreach to those folks. And another point I want to make is these folks, they're not just non-filers, they're typically folks who have very low to no income. People who earned more than $2,500 qualified for the child tax credit in the past, so they would have been more likely to file their taxes already. So it's really getting those people with low to no income into the fold. So we covered some of this already, but the eligibility requirements are very generous. There's no income requirement. There is a phase out period, but we're not worried about those folks. And again, mixed status families do qualify with children who have SSNs. And then of those children, there's a few eligibility rules around who qualifies as a child, but basically it's around the relationship to the child. They have to be 17 or under, and they do need to live with the person for over half of the year and have a Social Security number and be a dependent. If we can turn to the next slide. Okay, so there are basically, so this is one of the important things to know about the CTC. So a lot of folks don't actually need to take any action to get the advance payments if they filed a 2019 or 2020 tax return already, or use the 2020 Irs Non-Filer tool. That was a non-filer form that created a simplified tax return to receive the stimulus payments. They should not do anything. And so if you see someone who's already done that, who's already received their stimulus checks, just tell them to sit tight. You don't want someone to file a second tax return because that will mess up, that will make the return go into error resolution. And then on the other side, action is required if the person has not filed a 2019 or 2020 tax return and has not received their stimulus checks. So in order to get the CTC, you either need to file a tax return or fill out the Irs Non-Filer Portal. So the Irs Non-Filer Portal was just released, which is very exciting. If you go to the next slide, there are some details on what that all will entail. So the Irs Non-Filer Portal is a way to register for these advance payments. It is a simplified tax return. It's basically the 1040, but a simplified version. And it does allow you to claim stimulus checks on it, even if you don't qualify for the CTC. So it's mostly for the CTC, but technically you can also use it to claim the stimulus checks. You do not need specific documents on hand to use it, which is amazing for folks who might have lost documents, and you don't need to submit bank account information or have a permanent address. We did, the link in the screen, create a guide to filling out the non-filer form that goes into the portal with more detail and has screenshots for everything you might see there. There is a second portal that just came out recently. We are just starting to look at what the portal has, so don't know everything yet. But basically, the second portal is the CTC Up portal. So the non-filer portal is to sign up for the actual tax credit, and the CTC Up portal is to opt out of advance payments or change information. So for now, all people can do is use it to opt out. Eventually, folks will also be able to update life changes. So if they had changes in income, marital status, number of children, or their bank account information. And what we don't know is when these additional portal features will be available. You know what, I'll talk about Safe Harbor later on. So there are really two tracks with outreach. The first is to raise awareness, so informing folks about the availability of these payments, when they need to take action, and then driving them towards these portals if they do need to take action. And then the second path is really to help non-filers get these payments. So of course, we know that for folks who still have not filed taxes or used the non-filer form, they really do need the most support. And so I'll talk through some of the options that you all have to help people sign up. So of course, Medicaid agencies are a trusted source of information for many of these families, right? So Medicaid agencies can use their contacts that they're already talking to, like by phone, in person, or in writing, to inform them of this credit. They can add messages to their websites and portals, include flyers for mailings, send texts, emails, have recorded messages on calls for callers, and incorporate information into scripts. So all of these options, we are right now, they're not ready yet, unfortunately. We were waiting for the non-filer portal to open, but we are working on a lot of these outreach materials. Right now, we're working on text message scripts, email scripts, newsletter scripts, and flyers and all of that. So in the next couple of weeks, they will be available on the EITC outreach website for you all to use. So hopefully we can make this a little bit easier for you all. On the next slide, you'll see, so here, as I mentioned earlier, the best way to really support these folks is by helping people sign up. And so we've listed a few options that you have. The best way is if you do have time to help people use the Irs Non-Filer Portal, you don't need to be a tax preparer to use the portal. It takes about 20 to 30 minutes, depending on what information they have on hand. And that's really the best thing that you can do, is like answering questions and really walking someone through that process. For folks who don't have the time to do that, another option is to provide computers or laptops or tablets to use the non-filer portal. Unfortunately, the portal currently is not mobile friendly. It doesn't resize to phones. And so a lot of people who don't have computer access really can't fill out the form very easily. And another thing we are working on is we have our non-filer guide already, and we are making a printable version for folks who can't walk someone through the portal themselves, but might want a guide to have in person. If you can go to the next slide, we have just a couple other options here. I won't go through them in detail, just wanted to share some options here, but we are writing, we're working on a paper now, and we're going to have a bunch of one-pagers on how different agencies can support with CTC outreach. That'll have a lot of this information in there. So if you can skip to the next slide, sticky situations. So I wanted to just cover some of the things that might come up if you are supporting people with claiming the CTC. So one thing that we have heard from folks, especially folks that are talking to community change, are that there's really a fear and shame around being a non-filer. So if you haven't filed taxes in many years, and we know that like a lot of the folks that are still non-filers at this point are in this category, there's really a lot of fear around the IRS. And so making sure that you feel ready to like reassure folks that it's going to be okay, that it is unlikely that anything bad will happen, because people are afraid of audits. A lot of people will have already filed their taxes. So if someone has already gotten their stimulus checks, it's really important to tell them to just sit tight and wait for the payment because you do not want to file a second tax return. So that's number 2. For number 3, recovery rebates, for anyone who has not yet gotten their stimulus checks and is also using the non-filer portal to do that. This shouldn't happen, but if for some reason folks got a small amount of the stimulus, but not the full thing, and they're using the portal for that, it is very important to get the right number in the recovery rebate section of the form, because otherwise it can go into like error resolution and delay the refund further. Another couple issues I wanted to point out were just that a lot of folks are worried that the advance payments are a loan. So reassuring folks that that is not the case. And there are a lot of folks who don't have an address or bank account information. So with all of this, I know we are close to time. There is a link to some of the challenges, and you can read through some of the ways to overcome barriers that we have covered on the website. And so, yeah, we'll just skip to the Ctc resources that we've created. So we do have a link to the Ctc FAQs there. I can drop some of these in the chat when I'm done talking. And we're going to be creating a lot of outreach materials that will be available soon, including social media templates, phone scripts, flyers, and all of that good stuff. And for folks who are interested in referring people out around the Ctc, you can refer folks to 211. They can answer some simple questions there and direct folks to a local free tax filing site. And a great website to refer folks to is getctc.org. That website will link to the Irs Non-Filer form with some guidance. And when there is availability, they will also link to a virtual full VITA service. So that's great too. And then, yes, we have a few links here for government resources that I will not cover. And yeah, if you have any questions, please feel free to contact me. And then I have a request to look at a question. So it says here from Allison, for CTC, if someone has new dependent children in their custody, since their recent tax filing, am I correct that the non-filer portal is not an option? They will need to wait for the additional functions to be added to the second portal. Yes, if you have any changes in the number of children that you're claiming in 2021, then wait for the CTC Up portal to open.
Great. Thank you, Jenny, so much. I think each of these could be a separate webinar, but we wanted to just kind of give you a little bit of taste of all the different things. And obviously there's so much going on about the CTC and so much more to come. So I'm glad you all had a chance to meet our wonderful colleague and have our information. So please reach out as additional things happen. And thanks for considering doing this as well, in addition to all the incredible work you're doing around Medicaid. Connecting people to other benefits can be so valuable, especially when you talk about overall health and well-being of a family. So as we're at time, we're not going to really get into any other questions right now, although you've got all of our contact information. We will be sending out these slides probably early next week, along with the recording of the webinar. So please take a look at some of the information that we kind of breezed through and make sure to see all of the contact information from the resources today. Or you can, of course, reach out to myself or Farah if you have any questions or want to find the right person to get in touch with. So thank you again for the work you do, for being here today, and we look forward to seeing you again soon. Thanks so much. Bye-bye.